Hello friends, today we are going to discuss on sickle cell anemia case. So this was the 46-year-old female patient who is a known case of sickle cell anemia, presented with the chief complaint of joint pain and abdominal pain since 2 days and fever 15 days ago. She was initially admitted to the Arunodaya Hospital on 22nd of December for blood transfusion, and during transfusion she developed pain in the hands and legs, and she also developed uneasiness. So transfusion was stopped and the all routine blood investigations were sent, and the abnormality was the liver function enzymes were markedly elevated. So she shifted to the Apollo Hospital for further care. On 24th of December, she came to Apollo Hospital. On arrival, her pulse rate was 105, blood pressure was 113 by 73, respiratory rate was 17, saturation was 95%. On CVS examination, S1, S2 was present. The respiration, air entry was equal on both sides. For abdomen, it was soft, and the tenderness was present on the right hypochondrium region. And CNS wise, she was conscious. This lady was severely pale and yellowish discoloration was present on the sclera. So initially we have seen the investigations like chest X-ray, ABG, USG abdomen, since there was a tenderness in the right hypochondrium region and all the blood investigations. So initial blood investigation showed HB of 6.8, WBC 11, platelet count 1,28,000, creatinine was 4, bilirubin was 14, SGOT was uh, SGOT was 3,571, SGPT was 2,258, and ALP was 160. So other investigations which was abnormal was tropi, which was 33,000, PCT was 62, serum iron was 244, iron binding capacity was 105, fibrinogen, which was an inflammatory marker, came out to be raised, which is 243. Transferrin saturation was 125, and the ferritin was very high, which is 16,500. So this was suggestive of acute iron overload. So since she was constantly complaining of abdominal pain and tenderness was present on the right hypochondrium region, we did the USG abdopelvis and it showed enlarged liver of 17 centimeter, altered coarse ecotexture with slightly irregular margin, post cholecystectomy status seen. Both kidneys and pancreas was appear normal in size. And the 2D echo showed ejection fraction of 55 to 60%, no regional wall motion abnormal. On 25th of December, she started complaining of breathing difficulty. O2 requirement was increased. Patient was put on NIV support. ABG showed respiratory acidosis. So CT chest was done to find out any focus of infection is there or not. So this was the CT chest of that patient. So it showed the small area of consolidation with air bronchogram involving lateral basal and the posterior basal segment of left lower lobe, which was suggestive of infective etiology. Then bilateral minimum pleural thickening was present and mild cardiomegaly. So we did further we did electrophoresis and the peripheral smear for this patient, which showed HbS of hemoglobin S of 72%, which was suggestive of sickle cell. And on peripheral smear, this peripheral blood smear examination showed normochromic macrocytic ovulocyte, then epileptocytes, sickle cell, and some target cell, and many polychromatic macrocytes are seen. So this ABG showed the mixed acidotic picture. So treatment, what we have given is in view of acidosis, we gave sodium soda bicarb, 50 mg TDS. So the nephro consultation was given in view of raised creatinine. So and they have initiated SLATE in view of a raised creatinine and reduced urine output. Then in view of raised PCT and the entire picture was suggestive of the infection in lung, which was because CT chest showed consolidation. So we have started her on meropenem and targocid. Then she was constantly complaining of abdominal pain, so we have started her on fentanyl infusion, and blood transfusion was given in view of low HP. So her blood investigation on next day, that was on the 25th of December, her HB was improved to 8.1. WBC was 4.86, which was initially 11,000. Platelet were 1 lakh 36,000. Creat came down to 1.85. Bilirubin was still on the higher side. It was 14, and SGOT, SGPT, ALP, that was they were severely deranged. So further, we did a USG abdomen. Again, we have repeated USG abdomen for this patient to rule out portal vein thrombosis, which came out to be normal. Then her blood investigation on 26th of December and 27th of December, her HB was still on the lower side only. And then her creat was slightly on the higher side on 27th of December, which was 2.86. Her bilirubin, SGOT, SGPT, and ALP was still deranged, and the PCT came down to 18. So creatinine was increased strain, but the urine output of the patient was is less. So we have started her on Lasix infusion, and we have continued the same antibiotics. And in view of deranged LFT, the mucomix infusion was started. So this is the blood investigation of the patient on 28th, 29th, and 30th December. As we can see, the hemoglobin it's still on the lower side. Then creat was also high. That was it was constantly in the range of 2.46 to 2.96, and our SGOT was so initially on the higher side, and then it started showing the decreasing trend. On 29th of December, this patient had one episode of GTCS, which was terminated with the MIDAS, and immediately we have shifted this patient for the CT brain. This was the CT brain of this patient, which we did. So CT brain reveal approximately 5 to 6 centimeter maximum length and 1 to 2 centimeter in thickness of acute subdural hematoma on the right parietal convexity, causing the mid-mass effect on underlying brain parenchyma, and there is no midline shift on the transtentorial herniation. So we have started on injection Levipil, PRBC and platelet transfusion was given. So this we can explain this event by the vaso-occlusive crisis, in which adult will show the more incidence of intracranial hemorrhage. So this was the blood report of the patient on 31st of December, 1st of January, and the 2nd of January. As we can see, her creat is on the HB is she's constantly maintaining HB between 8 to 10, and her creat is decreasing trend, and her LFTs were uh, also showed decreasing trend, improving trend, and the PCT came out to be normal. That was 1.74. So and we have also sent all blood cultures to rule out any other bloodstream infection, which came out to be negative. So there was no ICU issue for this patient, so we shifted this patient to wards. But in ward, she started spiking fever, and all blood cultures and the urine cultures were sent again. So her urine culture showed the Enterococcus faecium, which was the vancomycin resistant strain. So we have started her on the daptomycin, 700 mg IV stat, and then 350 mg IV OD. The patient fever was not subsiding, so we have given the negative coverage also, and the antibiotics were escalated to zavicefta. So patient was persistently complaining of abdominal pain, fever spikes were still present, crepes were there on the left side of the chest. So USG, abdopelvis, and CT chest was repeated. So this time liver showed the mild altered coarse ecotexture with the irregular margin and the nodular counter, which was suggestive of the liver parenchymal disease, shrunken fibrotic spleen, and the bilateral renal cyst of size 2.2 to 1.7. Then minimal interbowel free fluid was noted. And as like our previous CT report, this CT report also showed small area of consolidation with air bronchogram on the same site on the lateral and the posterior basal segment of the left lower lobe, which was suggestive of infective etiology, but it was resolved as compared to the previous CT scan. So her latest lab reports, according to her latest lab reports, her HbA was 7.6, WBC 11, then creat was 0.64, then bilirubin 2, ALP is 314, and PCT is 0.48. Thanks. Now we'll have a discussion on the sickle cell crisis. So, sickle cell disease or sickle cell anemia is a lifelong blood disorder characterized by the red blood cell that assume an abnormal rigid sickle shape. Sickling decreases the cell's flexibility and results in the risk of various complications. So, sickling occurs because of the mutation of the hemoglobin gene. The life expectancy of the patient is 42 and 42 years for male and 48 years for female. So pathophysiology behind this is sickle cell anemia is caused by the point mutation in the beta globulin chain of the hemoglobin, causing amino acid glutamic acid to be replaced with the hydrophobic amino acid valine at 6th position. Beta globulin gene is found on the short arm of the chromosome 11, and the association of the two mutant beta globin subunit forms the hemoglobin S. So the loss of blood cell elasticity is the central of the pathophysiology of the sickle cell disease. And the normal red blood cells are quite elastic, which allows the cell to deform to pass through capillaries. In sickle cell disease, the low oxygen tension promotes the red blood cell sickling, and repeated episode of sickling damages the cell membrane, decreases the cell elasticity. These cells fail to return to the normal shape when normal oxygen tension is restored. As a consequence, these rigid blood cells are unable to deform as they pass through narrow capillaries, leading to the vascular occlusion and ischemia. The actual anemia of the illness is caused by hemolysis and the disruption of the red cells inside the spleen because of the mischief. Although the bone marrow attempts to compensate by creating new red cell, it does not match the rate of destruction. Healthy red blood cell is typically live 90 to 120 days. So signs and symptoms. The vaso-occlusive crisis is caused by the sickle-shaped red blood cell that obstruct the capillaries and restrict the blood flow to the organ, resulting in ischemia, pain, and often organ damage. The frequency, severity, and the duration of the crisis vary considerably. Now, the hemolytic crisis. The premature destruction of the sickle erythrocyte occur both extravascularly and intravascularly. Hemoglobinuria and the oliguria may be present. Palar develop rapidly and the icterus is common. Frequently, the palar listlessness and the mild icterus develop more insidiously. The urine may be dark in color due to presence of excess urobilinogen, and anemia is usually orthochromic but may be either normocytic and macrocytic. Reticulocytosis is often marked, and there may be many erythroblasts in the peripheral blood. So in sequestration crisis, there is massive pooling of the red cell in the visceral organ, especially splenomegaly may be marked, but sometimes disappear in the later childhood. The splenectomy is indicated when there is hypersplenism. Immune deficit. The propensity of the child with sickle cell disease to streptococcus pneumoniae infection is related to the impaired splenic function and diminished serum opsonizing activity. Now, this patient, they will be like there will be chronic anemia. So, the chronic hemolytic anemia is the hallmark of the sickle cell disease, and the sickle erythrocytes are destroyed randomly with mean lifespan of the 17 days. Erythropoietin levels are inappropriately low, suggesting the presence of subclinical renal disease. Now, the exacerbation of the anemia. Hemolytic anemia may be exacerbated by the any of several events, a plastic crisis and acute splenic sequestration, less commonly sequestration in other organs, chronic renal disease, bone marrow necrosis, deficiency of the folic acid, iron, and the hyperhemolysis. So, acute painful episode. Acute pain is the first symptom of the disease in more than 1/4 of the patient and the most frequent symptom after 2 years. The frequency of the pain peak between the 19 and 39 year. Pain may be precipitated by the events such as cold, dehydration, infection, stress, menses, alcohol consumption, but most painful episodes have no identifiable cause. Acute recurrent painful episode due to vascular occlusion in various organs, but especially in the bone, is hallmark of the disease. So, preventing this painful episode, the measure to prevent and reduce the frequency of the painful episode include treatment with hydroxyurea and the repeated blood transfusion. So this hydroxyurea is the anti-cancer drug which promotes the production of the hemoglobin F, the fetal form. The initial dose in the adult is 10 mg per kg per day. Repeated blood transfusion may reduce the frequency of painful episode in sickle cell anemia, but their role is controversial. Now we'll see the neurological complication. Neurological complication occurring in 25% of cases, and it includes transient ischemic attack, cerebral infarction, cerebral hemorrhage, seizure, unexplained coma, spinal cord infarction, compression, central nervous system infection, vestibular dysfunction, and the sensory hearing loss. Acute cerebral infarction is most frequent in the children, where intracerebral hemorrhage is most prevalent in the adult. So the microaneurysm involving fragile dilated vessel which develop as compensatory collateral circulation around the areas of infarction seem to be responsible for hemorrhages in adults. Unlike the other vascular bed, large vessels rather than the microvessels seem to be the site of occlusion. Transcranial ultrasonography of the large cerebral vessel may predict which patient they are at risk of stroke. So prophylactic transfusion decreases the risk of first stroke in children with the sickle cell anemia with abnormality on the transcranial Doppler ultrasonography. Now the next symptom is acute chest syndrome. Symptom and site of the acute signs of acute chest syndrome include dyspnea, chest pain, less commonly abdominal pain, fever, tachypnea, leukocytosis, pulmonary infiltrate on the chest radiograph. This event has approximately 10% risk of mortality. The process is usually due to infection in the vasoocclusion, but it may also be result of non-cardiogenic pulmonary edema, pulmonary embolization from distant thrombus, or bone marrow infarction. The major danger of chest pain, acute chest syndrome, is hypoxemia. It results in vasoocclusion, which creates the risk of multi-organ failure. Acute pulmonary hypertension is frequent during vasoocclusive crisis and acute chest syndrome and is associated with high risk of death. Lung ultrasound may be preferred to chest radiography for bedside detection of typical lower lobe consolidation during adult acute chest syndrome. Now, hepatobiliary complication. At least two-thirds of the sickle cell anemia have hepatomegaly. 75% have cholelithiasis. 90% of patients with cholelithiasis undergo cholecystectomy either prophylactically or after episode of acute calculous cholecystitis. Hepatic crisis or sickle cell intrahepatic cholestasis is is manifested by sudden onset of right upper quadrant pain, uh, progressive hepatomegaly, increased bilirubin level, mostly indirect, and the prolongation of prothrombin and partial thromboplastin time. Levels of the liver enzyme gamma glutamyl transpeptidase, alanine aminotransferase are also elevated. Now, the total blood exchange in which whole blood is removed and replaced with the red cells in the fresh frozen plasma is recommended if total bilirubin level increase progressively to values greater than 50 mg per day. At that level, the growth hormone time are usually prolonged. Blood exchange should be continued until the level of hemoglobin S is reduced to less than 30% and the population abnormality is corrected. Now the renal complication, the hypoxic, acidotic and the hypertonic microenvironment of the renal medulla causes the sickling of the red cell in the vasa recta, leads to the infarction of the renal medulla, hypostenuria and the hematuria. Management of the hematuria in patient with sickle cell disease is conservative. Strict bed rest alone results in spontaneous remission of most patients. In few instances, the gross hematuria may be severe enough to warrant blood transfusion. The use of epsilon aminocaprinic acid and the desmopressin acetate may effectively control hematuria. Then next is impaired potassium excretion. Potassium excretion is also impaired. Episode of hyperchloremic acidosis have been reported. Hyperkalemia may be spurious due to in vitro hemolysis, but hyperkalemia is reported in association with type 4 renal tubular acidosis. The acidosis due to hypoaldosteronism. Renal insufficiency is present in most of these patients. Now, the next is nephrotic syndrome. Nephrotic syndrome with or without hypertension occurs frequently in patients with sickle cell disease. Microscopic hematuria, proteinuria, hypertension, and nephrotic syndrome are marker of incipient end-stage renal failure. Proteinuria occurs in 26% of the patient with sickle cell disease, and elevated serum creatinine occurs in about 7%. The pathologic region is usually glomerular enlargement and the peripheral or focal segmental glomerulosclerosis. Treatment with the angiotensin converting enzyme inhibitor NL3 seemed to reduce the degree of proteinuria in sickle cell disease, suggesting that the capillary hypertension may be pathogenic factor in sickle cell nephropathy. Once the chronic renal failure progressed to end-stage renal disease, the patient require chronic hemodialysis and are candidate for the kidney transplant. Now, the cardiac complication. Cardiac complication in patients with sickle cell anemia include high output heart failure, right heart failure, congestive heart failure, cardiac hemosideration, and cardiomegaly, myocardial ischemia. Although mitral valve prolapse was reported to have high prevalence in the sickle cell disease, the signs and symptoms of mitral valve prolapse include chest pain, dyspnea, fatigue, syncope, palpitation, which overlap with those with the sickle cell disease. Patient with the mitral valve prolapse and the significant mitral regurgitation should require prophylactic antibiotic therapy before dental procedures. Now, the bone complication, the chronic tower skull, bossing of the forehead, the fish mouth deformity of the vertebra are the result of extended hematopoietic marrow causing the widening of the medullary space, thinning of the trabecula and the cortices, and osteoporosis. The excruciating pain of the bone infarction in the hand-foot syndrome that occurs around the age of 12 years is often first symptom in sickle cell disease. This dactylitis resolves spontaneously and is treated with hydration and the analgesics. Necrosis occurs with the equal frequency in femoral and humeral heads. The femoral heads are more commonly undergo progressive joint destruction as a result of chronic weight bearing. Arthritic pain, swelling, and the effusion may be related to the periarticular infarction or to gouty arthritis. Bone marrow infarction causes the reticulocytopenia, exacerbation of anemia, leukoerythroblastic picture, and sometimes pancytopenia. Now, ocular complications include anterior chamber ischemia, tortuosity of the conjunctival vessel, retinal artery occlusion, angioid strix, proliferative retinopathy, retinal detachment, and the hemorrhage. Now, infectious complication of sickle cell disease are the major cause of morbidity and mortality. Streptococcus pneumoniae is the most common cause of bacteremia in children with sickle cell disease. The second most common organism responsible for the bacteremia in the children is H. influenzae type B, which has occurred for 10% to 25% episode. Bacteremia in the older patient is most likely due to E. coli and the other gram-negative organism, as are urinary tract infection. Meningitis in sickle cell anemia is primarily a problem of infant and young children and is caused most frequently by Streptococcus pneumoniae. Osteomyelitis occur more commonly in sickle cell disease than in the normal individual, probably as a result of infection of the infected bone. And in this population, osteomyelitis is commonly caused by Salmonella species. Now, the diagnosis of sickle cell anemia, the blood film may show features of hyposplenism, that is, target cells in the oval Jolly bodies. Sickling of the red blood cells on the blood film can be induced by addition of sodium metabisulfite. The presence of sickle hemoglobin can also be demonstrated with sickle solubility test, a mixture of hemoglobin S in hemoglobin in reducing solution such as sodium dithionite gives the turbid appearance, whereas normal HB gives the clear solution. Abnormal hemoglobin form can be detected on the hemoglobin electrophoresis, a form of the gel electrophoresis on which various type of hemoglobin move at varying speed. HBSS and the HBSC can be identified here. The diagnosis can be confirmed with the high performance liquid chromatography. The genetic testing is rarely performed, as other investigations are highly specific for HBS and the HBC. Acute sickle cell crisis is often precipitated by the infection. Therefore, urine analysis to detect focal UTI to look for focal pneumonia should be routinely performed. Now, the general management is the hydration. Dehydration and hemoconcentration are known to precipitate painful crisis in some patients. The maintenance of adequate hydration is very important where febrile condition increases fluid loss. During the therapy of acute complication, the use of oxygen is frequently recommended. Patients with the SS disease have lower arterial oxygen saturation in steady state, and this may fall further during acute illness, especially in the acute chest syndrome. Under this condition, high level of inspired oxygen can be beneficial. Now, the blood transfusion. In addition to the normal hazardous cases of the blood transfusion, there are additional danger of hemosidrosis and the precipitation of crisis. Generally, the indication of the blood transfusion is the hemoglobin level less than 4 to 5 gram in selected cases. For electrical and emergency surgical operation, the presence of formidable uh, complicating infection. Normally, the packed cells are transfused simply to raise the hemoglobin concentration level without increasing blood volume. So, relief of pain is the important aspect in the management of the painful crisis. Mild to moderate pain is often respond to the paracetamol. Severe pain, pethidine and the codeine have reduced the frequency of emergency room visits. Pentazocine morphine can also be used for severe pain necessitating a hospital admission. Intravenous infusion of the drug gives better and the more sustained pain relief. Hydroxyurea, the first approved drug for causative treatment of sickle cell anemia. Hydroxyurea was shown to decrease number and the severity of attack. This is achieved by reactivating fetal hemoglobin production in place of HbS that causes sickle cell anemia. Red cell transfusion, either simple or by exchange, is an established treatment option for preventing chronic organ damage, preoperative care, and acute complication of sickle cell disease. Blood transfusion is generally aimed at increasing total hemoglobin without exceeding the patient's basal value or 10 gram to avoid hyperviscosity. Thank you.